So today I'm going to talk about preeclampsia and eclampsia. The pathophysiology. Preeclampsia and eclampsia are hypertension disorders that many women are diagnosed with during pregnancy. These disease processes are defined by new onset hypertension occurring during pregnancy, meaning these disease processes affect only pregnant women. The specific pathophysiology is not well known. However, the marked characteristics are hypertension accompanied by a degree of edema, as well as protein present in the urine. Eclampsia includes these same characteristics, but can only be diagnosed after a seizure has occurred. Clinical manifestations or signs and symptoms. Preeclampsia is characterized by an increase in blood pressure considered hypertension, edema or swelling in the arms, legs, hands, or face, and protein in the urine. There are a few levels of preeclampsia, mild and severe. After that, the disease progresses into eclampsia. Preeclampsia is characterized by blood pressure above 140/90 on more than one occasion, +1 proteinuria, or protein in the urine, and generalized edema. Severe preeclampsia is further defined by blood pressure at or greater than 160/110, proteinuria +5. With severe preeclampsia, the patient may also have frequent headaches and visual disturbances, like seeing a fog, trying to look through a fog, double vision, or blurry vision. Eclampsia consists of high blood pressure, protein in the urine, severe edema, and seizures. Some of these symptoms may be normal during pregnancy without hinting at preeclampsia, as many women swell and have blood pressure changes. However, these symptoms together and marked increase in blood pressure are what characterize preeclampsia and eclampsia. The disease progression. There are several stages of preeclampsia before a patient may potentially reach eclampsia. There is also the diagnosis of gestational hypertension. Gestational hypertension is high blood pressure, 140/90, after the 20th week of pregnancy with no other characteristics, meaning women who are diagnosed with gestational hypertension will not have swelling or the protein in the urine. Mild preeclampsia is the first stage many women can or may experience. Preeclampsia is when blood pressure continues uncontrolled. The mother may then experience severe preeclampsia. This may be accompanied by more symptoms than we see in mild preeclampsia, like gastric pain, increased protein in the urine, increased edema, possible pulmonary edema, decreased urine output, chronic headaches, and visual disturbances. Eclampsia is when the disease progresses further. The woman may begin to have seizures. At this point, the woman is at an increased risk for fetal demise, increased mortality rate, and higher risk of complications. Eclamptic convulsions are considered emergent and must be treated immediately. There are many risks associated with preeclampsia and eclampsia, including, but not limited to, renal disease, abruptio placentae, multi-organ failure, hemorrhage, or maternal or fetal loss. Treatment of preeclampsia. Monitoring of the woman and fetus, fetal movement record, non-stress test, and daily kit counts need to be done. Bed rest, left side lying, to lower blood pressure and increase blood flow to the placenta is recommended. Diet should include increased protein and decreased sodium. Daily weight should also be done to monitor excess fluid volume. Daily weights are a primary source for information about a woman's water intake or water levels. Tests recommended for the mother may include blood and urine tests to see if preeclampsia is progressing, other tests to assess platelet counts, liver enzymes, kidney function, and urinary protein levels. Tests for the fetus may include ultrasound every 3 to 4 weeks, heart rate or monitoring by a Doppler starting at 30 weeks, assessment of fetal growth, and amniotic fluid assessment. If polyhydramnios occurs, amniocentesis may be ordered. Treatment of severe preeclampsia. Bed rest, left side lying to try and decrease blood pressure and increase blood flow to the placenta. Diet, including high protein and decreased sodium, and again, daily weights to monitor for excess fluid. Hospitalization may also be done so the mother can be continuously monitored and provided with a quiet, dark environment to avoid stressful stimuli, which may in turn increase blood pressure. Medications may include magnesium sulfate used to lower blood pressure and depress the central nervous system to prevent seizure. Antihypertensives may be used in conjunction with this. The antihypertensives we typically use are methyldopa, nifedipine, hydralazine, and labetalol to treat high blood pressure, 34 weeks gestation or later. The American College of Obstetrics recommends delivery as soon as medically possible. If less than 34 weeks gestation, healthcare providers may prescribe betamethasone to speed maturation of the lungs. Further treatment for preeclampsia. Treatment of eclampsia. Immediate treatment is needed to stop seizures and treat high blood pressure and deliver the fetus. Anticonvulsants like mag sulfate are given to treat active seizures and prevent more in the future. Antihypertensives are again used, methyldopa, nifedipine, hydralazine, and labetalol to lower blood pressure. We've also given an example nursing diagnosis. The diagnosis that we have chosen is deficient fluid volume related to fluid shift from intravascular to extravascular space secondary to vasospasms. The circulatory effects are as follows. Plasma colloid osmotic pressure decreases as serum albumin levels decrease. Intravascular volume is reduced as fluid moves out of the intravascular compartment, which allows hemoconcentration, increased blood viscosity, and tissue edema. Interventions to treat. Encourage women to lie in left lateral recumbent or left side lying. As we previously discussed, this position decreases blood pressure on the vena cava, thereby increasing venous return, circulatory volume, and placental and renal blood flow. This helps promote diuresis and lower blood pressure. Assess blood pressure every 1 to 4 hours as necessary. Frequent monitoring will assess for progression of the disorder and allow for early intervention to ensure maternal and fetal well-being. Monitor urine for volume and proteinuria every shift or every hour per agency protocol. Monitoring provides information to assess renal perfusion. Proteinuria is the last cardinal sign of preeclampsia to appear. As the disorder worsens, the capillary walls of the glomerular endothelial cells stretch, allowing protein molecules to pass into the urine. Normally, urine wouldn't contain protein, so readings of 3+ or 4+ indicate a loss of 5 grams or more of protein in 24 hours. Urinary output decreases when there is a reduction of the glomerular filtration rate. If urinary output falls below 30 milliliters per 1 hour, or less than 700 milliliters in a 24-hour period, the healthcare provider should be notified immediately. We would also want to assess deep tendon reflexes and clonus. Hyperreflexia may occur as preeclampsia worsens. This elicits deep tendon reflexes, which provide information about the central nervous system and is also used to assess magnesium sulfate toxicity. Reflexes are graded on a scale from 0 to 4. A rating of 4 is abnormal and absent with high magnesium. Clonus, an abnormal finding, is present if the foot jerks or taps the examiner's hand. The examiner counts the number of taps or beats. The presence of clonus indicates a more pronounced hyperreflexia and is indicative of CNS irritability and impending seizure. To recap, we've now covered the main points needed to understand the disease progression of preeclampsia and eclampsia. We've also discussed what's going on underneath the surface of the skin or the pathophysiology. We've also discussed the disease progression and some treatments to be expected. We've included our nursing diagnosis and potential interventions that should be done to protect both patient and baby. It's important to assess all pregnant women accurately and thoroughly to ensure the safety for both mom and her precious unborn baby. Thank you.